The ductus arteriosus is a duct that communicates between the descending aorta and the pulmonary artery or the pulmonary trunk. And its presence ensures that the oxygenated blood that comes from the fetal circulation during the fetal life, it goes to the systemic circulation. As we know that there are 3 types of shunts in the fetal circulation, but 2 major shunts inside the heart, which are the patent foramen ovale, which will be discussed later, and the ductus arteriosus. Those 2 shunts ensures that the oxygenated blood that comes from the placenta and the umbilical vein, when it goes through the inferior vena cava to the right atrium of the fetus, it has 2 pathways to go through. One of them is through the patent foramen ovale, which ensures that a higher concentration of blood goes to the brain. So this is the importance of the patent of the foramen ovale, is to ensure that the more oxygenated blood is reaching to the vital organ, the brain. And the rest of the blood goes to the right ventricle, from the right ventricle to the pulmonary trunk, and from there, the pulmonary trunk, the ductus arteriosus, it shunts the blood from the right to the left circulation, to the systemic circulation, into the descending aorta and the rest of the body. This is the importance of the ductus arteriosus. And how this duct is kept open during fetal circulation, this is very important for you to know, is that there are 2 reasons it is kept open. One of them is the prostaglandin E2 that is produced from the placenta. The placenta is the main source of prostaglandin E2 during fetal circulation that keeps the ductus arteriosus open. And the other cause is that the fetal circulation, it has a low oxygen content. This low oxygen content reaches the oxygen saturation of the fetal heart, it reaches almost 60% only. So the low oxygen content, it keeps the ductus arteriosus in a patent state during the fetal circulation. What happens after birth? After birth, I loses the placenta. The fetus starts to take the air and with higher oxygen, and the oxygen increase after birth more to than 95%. So the higher oxygen content and the loss of the prostaglandin E2 will cause an immediate closure of this ductus arteriosus that starts to happen in the very first 24 hours. Within 15 hours, it starts to happen, this closure, and it will be complete within 2 to 3 weeks. So if this closure fails, if the ductus arteriosus fails to close after those 2 to 3 weeks, an element of patent ductus arteriosus will manifest later in life. The patent ductus arteriosus, what are the clinical sequelae of this patent ductus arteriosus? First of all, we must know that, as you can notice here anatomically, that the ductus arteriosus, this communication is located beyond the level of the left subclavian artery in the descending aorta. And this is an important clue in the question. Sometimes they try to deceive you with the MCQ questions. They say that it is distal to the right left subclavian. No, it is not the right, it is the left subclavian. And as it causes this left to right shunt, carrying with it more oxygen content. So what are the clinical sequelae? Is that as long as there is more blood flow through this ductus arteriosus to the pulmonary artery, there is more blood reaching the lungs, right? More blood reaching the lungs. And this will cause, the first thing to do or affect, it will cause pulmonary hypertension. And as long as there is more blood flow to the lungs, this more blood flow in return will go back to the heart. So more blood reaching the left heart, left atrium and the left ventricle. More volume of blood in the left heart, what will it cause? It will cause left ventricle and left atrial dilation. Those are the most important two sequelae, and from here the patient starts to develop symptoms. What are the symptoms that are expected in these conditions? From pulmonary hypertension, he will start to develop dyspnea, exertion, and exercise intolerance. And from the left heart dilation and left atrial dilation, as we said, any dilation of the left atria, it will increase the risk of developing atrial arrhythmias like atrial fibrillation. What about the risk of infective endocarditis? Also, the risk of infective endocarditis is increased as the jet from the high systemic circulation in the descending aorta to the pulmonary lower pressure pulmonary artery. This jet will hit the walls of the pulmonary artery and will increase the risk of developing infective endocarditis at the walls here. This is an image showing calcification of the patent ductus arteriosus on a chest X-ray. How we diagnose this condition? We use definitely two-dimensional echo with the 8 history and the physical examination, and the test of choice is two-dimensional echo. We examine it through the supra-sternal view, and we can see the communication and the shunt in this area between the pulmonary artery and the pulmonary, between the descending aorta and the pulmonary artery, as we will see. We already went through this. So what are the clinical manifestations or clinical signs? Two important signs. What do you expect to find in these patients as long as there is a duct through which blood flows during both periods of the cardiac cycle, which are the systole and diastole? So we might find a continuous machinery murmur. What does continuous murmur means? It means that it is continuous through systole and the diastole, here best at the first and second left intercostal space. So a continuous murmur during both systole and diastole, here best at the first or second intercostal space. This is the hallmark of the patent ductus arteriosus. And the second sign, as long as there is a continuous diastolic runoff, continuous diastolic flow through this duct, this will cause an element of a wide pulse pressure. This is the same thing that happens during in conditions of aortic regurgitation. So where do we find wide pulse pressure? We find it in aortic regurgitation, and the second condition is in the patent ductus arteriosus. In aortic regurgitation, the blood flows back from the aorta to the from the aorta through the aortic valve back to the ventricle, which happens during diastole. So the flow of blood goes into the systemic circulation and back of it during diastole back to the heart. This is in aortic insufficiency or regurgitation, and this will cause a wide pulse pressure. And here, as there is a continuous diastolic flow through the ductus arteriosus, it will cause also a wide pulse pressure with pounding peripheral pulses. If the patient is left untreated by time, the pulmonary hypertension will continue to rise, and this might become very high pulmonary artery pressure and even becomes higher than the systemic blood pressure. And at this level, the reversal of the shunt from left to right, it will reverse from a right to left shunt. And this is the physiology of Eisenmenger syndrome. So what happens exactly? What's a clinical sign that can we find in this Eisenmenger pathophysiology of the ductus arteriosus? As we said, the ductus arteriosus is located beyond the level of the left subclavian. Thus, when there is reversal of the shunt from the pulmonary to the aorta, this deoxygenated blood, it will go into the descending aorta beyond the level of the left subclavian artery. So what do we expect to find in examination? We expect to find what is called differential cyanosis. Differential cyanosis is that cyanosis of the lower limbs and the left upper limb, sparing the right upper limb and the head and neck. This is pathognomonic and classical for the Eisenmenger physiology in patients with Eisenmenger syndrome. We should not forget this differential cyanosis. This is a real image, an MRI image of the aorta and the communication between the aorta. This is the ductus arteriosus. This is that site with causing this left to right shunt. You can see the jet here in the pulmonary artery. This is the ductus arteriosus. When do we treat and when we should not treat? We treat when the patient is at the very early symptoms. We should treat. Or the patient started to have higher pulmonary artery pressure, we should start to treat. When the patient started to have any element of left ventricle or left heart overload with left atrial dilation or left ventricle dilation, we should treat, especially when the pulmonary artery pressure is not very high, less than 2/3 the systemic circulation. But if the patient has no symptoms at all, with no hemodynamic sequelae, and it's very small, with no murmur, or the patient has developed Eisenmenger physiology, then we should not treat these patients. How do we treat them? We need to close this ductus arteriosus. How do we close it? We use two methods to close the ductus arteriosus, either percutaneously or surgically. Percutaneously, we use either what we call coil. This is a coil. We insert this coil through catheterization and we deploy it here, and this coil, it will close the ductus arteriosus. And the other element is that we use the coil if the size is less than 3.5 millimeter, or we use an occluder device, the Amplatz ductal occluder, when the size is more than 3.5. Otherwise, it's very large or heavily calcified, then we use a surgical closure.